Infective endocarditis. Infective endocarditis, also called bacterial endocarditis, is an infection of the inner lining of the heart caused by direct invasion of bacteria or other organisms leading to deformity of the valve leaflets. Pathophysiology and etiology. When the inner lining of the heart endocardium becomes inflamed, a fibrin clot vegetation forms. The fibrin clot may become colonized by pathogens during transient episodes of bacteremia resulting from invasive procedures, venous arterial canalization, dental work causing gingival bleeding, GI tract surgery, liver biopsy, sigmoidoscopy, and so forth. Indwelling catheters, urinary tract infections, and wound skin infections. And third one, platelet and fibrin surround the invading microorganisms, forming a protective covering and causing the infected vegetation to enlarge. The enlarged vegetation, the basic lesion of endocarditis, can deform, thicken, stiffen, and scar the free margins of valve leaflets, as well as the fibrous ring annulus supporting the valve. The vegetations may also travel to various organs, tissues, spleen, kidney, coronary artery, brain, and lungs, and obstruct blood flow. The protective covering surrounding the vegetation makes it difficult for whole white blood cells and antimicrobial agents to infiltrate and destroy the infected lesion. Fourth, causal organisms include bacteria. Streptococcus viridans. Bacteremia occurs after dental work or upper respiratory infection. Staphylococcus aureus. Bacteremia occurs after cardiac surgery or parenteral drug abuse. Enterococci. Penicillin resistant group T streptococci. Bacteremia usually occurs in elderly patients over age 60 with genitourinary tract infection. Fungi. Candida albicans aspergillus. C. rickettsia. Fifth, infective endocarditis may develop on the heart valve already injured by rheumatic fever, congenital defects, on abnormally vascularized valves, normal heart valves, and mechanical biologic heart valves. Sixth, infective endocarditis may be acute or subacute depending on the microorganisms involved. Acute algae manifests rapidly with danger of intractable heart failure and occurs more commonly on normal heart valves. Subacute IE, that is infective endocarditis, manifests a prolonged chronic course with a lesser chance of complications and occurs more commonly on damaged or defective valves. Infective endocarditis may follow cardiac surgery, especially when prosthetic heart valves are used. Foreign bodies such as pacemakers, patches, grafts, and dialysis shunts predispose to infection. High incidence among drug abusers in whom the disease mainly affects normal valves, usually the tricuspid. Hospitalized patients with indwelling catheters, those on prolonged IV therapy or prolonged antibiotic therapy, and those on immunosuppressive drugs or steroids may develop fungal endocarditis. Relapse due to metastatic infection is possible, usually within the first 2 months after completion of antibiotic regime. General manifestations: fever, chills, sweats. Fever may be absent in elderly or in patients with uremia. Anorexia, weight loss, weakness, cough, back and joint pain, especially in patients over age 60, and splenomegaly. Skin and nail manifestation: petechiae, conjunctiva, mucous membranes, splinter, hemorrhage in nail beds, Osler nodes, painful red nodes on pads of fingers and toes, usually late sign of infection and found with a subacute infection. Janeway lesions, Janeways, Janeway's lesions. Light pink macules on palms or soles, non-tender, may change to light tan within several days. Fade in 1 to 2 weeks, usually an early sign of endocardial infection. Heart manifestations: new pathogenic or changing murmur. No murmur with other signs and symptoms may indicate right heart infection. Tachycardia related to decreased cardiac output. Central nervous system manifestations: localized headache, transient cerebral ischemia, altered mental status, aphasia, hemiplegia, cortical sensory loss, Roth's spots on fundi. Pulmonary manifestations usually occur with right-sided heart involvement, pneumonitis, pleuritis, pulmonary edema, pulmonary infiltrates. Embolic phenomena: lung hemoptysis, chest pain, shortness of breath, kidney hematuria, spleen, pain in upper left quadrant of abdomen radiating to left shoulder. Heart myocardial infarction, brain sudden blindness, paralysis, brain abscess, meningitis. Blood vessels, mycotic aneurysms. Abdomen, melena, acute pain. Diagnostic evaluations: varied clinical manifestations and similarities to other diseases make early diagnosis of infective endocarditis difficult, i.e. blood cultures, at least 2 positive serial blood cultures isolating bacteria or fungi. Elevated sedimentation rate, ESR rate, test indicative of anemia, mild leukocytosis, urine abnormalities indicating nephrosis. ECG usually normal. Echocardiography, identification of vegetations and assessment of location and size of lesions. Management: antimicrobial therapy based on sensitivity and causative agent. Penicillin G, vancomycin, gentamicin, clindamycin, rifampicin, alone or in combination for 4 to 6 weeks. The missed doses of antibiotics due to patient unavailability while of the unit of diagnostic tests are given after return to the unit. That means never should skip the dose or miss the dose. Missed antibiotic doses may be irreversible, deleterious consequences. Audiogram obtained before antibiotic regime initiated. Urine cultures obtained after 48 hours to assess efficacy of drug therapy. Repeat blood cultures obtained after 48 hours to assess efficacy of drug therapy. Close follow-up cardiologist. Supplemental nutrition. Surgical intervention for acute destructive valvular lesion, excision of infected valves or removal of prosthetic valve. Hemodynamic impairment, recurrent emboli, infection that cannot be eliminated with antimicrobial therapy, drainage of abscess or empyema for patient with localized abscess or empyema, repair of peripheral or cerebral mycotic aneurysm. These conditions need surgical intervention. Complications: severe heart failure due to valvular insufficiency, uncontrolled or refractory infection, embolic episodes, ischemia or necrosis of extremities and organs. Last one, conduction disturbances. Thank you.